Hi all, thank you for joining my lecture on emergency situations. I am Dr. Windsor, and in this lecture I will be discussing patient emergency situations that occur most frequently in the operating room. Two that are the most pertinent to the surgical tech are cardiac arrest and malignant hyperthermia. By the end of this lecture, you should be able to define terms and abbreviations related to emergency situations, as well as identify emergency situations associated with anesthesia. You should also be able to discuss respiratory emergencies, including allergic reactions. Should also be able to identify and discuss medications used in respiratory emergencies. Also, you should be able to describe transfusion reactions, including the 3 different types of transfusion reactions. In addition to that, you should be able to define and discuss bronchospasm and laryngospasm, cardiac arrest, and explain the role of the surgical tech during those emergencies. You should also be able to list and describe drugs frequently used for cardiac resuscitation, as well as some miscellaneous ones. You should also be able to list and describe clinical signs of malignant hyperthermia, outline the basic course of treatment for hypothermia, and explain the role of the surgical tech during a malignant hyperthermia crisis. So, now that we know what we're going to learn, let's learn it. So first, let's start off with a review of some common terms that you will encounter during this lecture. Anaphylaxis is one of the respiratory emergencies we're going to talk about. Anaphylaxis refers to an unusual or exaggerated allergic reaction of an organism, like a human, to foreign protein or other substances. Asystole refers to the absence of heartbeat and indicates the need for cardiac resuscitation. Bradycardia and bronchospasms are both complications that relate to anesthesia care. Remember, bradycardia means slow heart rate, so that would be a heart rate that is less than 60 beats per minute. Bronchospasm is the involuntary contraction of the smooth muscle of the bronchi, making it difficult to breathe. If any of you listening out there have asthma or know someone who does, this can be a really frightening situation. And then lastly, here on this slide, diaphoresis. Diaphoresis refers to profuse perspiration, and it is a clinical sign of malignant hyperthermia, which we will talk about more in a bit. Hemoglobinuria means the presence of hemoglobin in the urine, and it may characterize hemolytic transfusion. A hemolytic transfusion reaction is a serious complication that can occur after a blood transfusion. The reaction occurs when red blood cells that were given during the transfusion are destroyed by the person's immune system. So when red blood cells are destroyed, the process is called hemolysis. Pyrexia is often believed to be an early indicator of malignant hyperthermia, but it's a late sign. Pyrexia refers to a fever or a febrile condition. Few more terms here. The last 3 terms that I want to review with you are tachycardia, tachypnea, and urticaria. Tachycardia, abnormally rapid heart rate of more than 100 beats per minute, and tachypnea, abnormally rapid respirations of more than 30 times per minute. These are both early clinical signs of malignant hyperthermia. Hives or raised skin patches are called urticaria, and urticaria is a sign of an allergic reaction. So if you joined me for my previous lecture on anesthesia, you might remember that one goal of anesthesia is to keep the patient as physiologically stable as possible throughout the duration of the surgical procedure. And if you haven't guessed by now, surgery and anesthesia significantly impact the patient's physiological state. Emergency situations might range from mild to life-threatening, and they can be a result of existing disease, trauma, the surgical procedure itself, anesthesia, or of some unknown etiology. As I mentioned previously, cardiac arrest and malignant hyperthermia are two emergency situations that are most pertinent to the surgical technologist. The respiratory emergencies associated with anesthesia include bronchospasm, anaphylaxis, and laryngospasm. Cardiac arrest and malignant hyperthermia are really rare emergencies, but are also really important for us to understand. As surgical technologists, we must be prepared to respond efficiently and effectively to any emergency situation that may arise in the operating room. It probably goes without saying that a better understanding of these situations enables us not only to anticipate the needs of the surgical team, but to provide the highest quality care possible. Wouldn't you agree that our patients deserve that? During this lecture, I will discuss each of these emergency situations in more detail. So as I mentioned previously, intraoperative respiratory impairment or obstruction may be the result of trauma, inflammation, allergic reaction, bronchospasm, or laryngospasm. Now, signs of an allergic reaction can occur in approximately 2 to 20 minutes, and they can persist for up to approximately 36 hours. Allergic reactions may be mild, or they may be severe or somewhere in between. Signs of mild allergic reaction include skin redness, hives, and raised red patches. Now, signs of a severe allergic reaction include serious cardiovascular and respiratory problems, which indicates anaphylaxis. If early signs of an allergic reaction are identified, it's going to be a best practice to discontinue the medications that could be triggering the reaction. The anesthesia care provider is going to administer 100% oxygen, increase IV fluids, and possibly even give a dose of epinephrine. As the surgical technologist in the room, your ability to identify an allergic reaction can save a patient's life. When the body is exposed to something that it is allergic to, it's going to react by releasing a number of proteins, including histamines. Histamine is a chemical that is created by the body, and it's released by white blood cells into the bloodstream when an immune system is defending against a potential allergen. Histamines also cause vasodilation, which can result in low blood pressure, hypotension. So there are two types of histamine blockers, also called antihistamines, that are administered during surgery to counteract histamine release. And they are H1 receptor antagonists and H2 receptor antagonists. H1 receptor antagonists are typically utilized to suppress the body's histamine-mediated effects in anaphylactic reactions. H2 antagonists are competitive antagonists at the parietal cell. Remember, those are the cells in the stomach that are responsible for making stomach acid. H2 receptors, parietal cell H2 receptors, are typically used to suppress gastric acid secretion. And I'm sure you're familiar with the H1 receptor antagonist called Benadryl or diphenhydramine. This is an over-the-counter medication that is typically taken for mild allergy, But in the operating room, it can be given IV to treat allergic reactions. And then common H2 receptors antagonists include ranitidine and famotidine. If conservative treatment of an allergic reaction is not effective, the allergic reaction may quickly progress to anaphylaxis, and that is the most severe systemic allergic reaction. And this can result in something called anaphylactic shock. Anaphylactic shock is characterized by a complete cardiovascular collapse, which can happen really fast, and it may include cardiac and respiratory arrest. Out of every 4,000 to 25,000 people that receive anesthetic agents, it's estimated that one person will experience anaphylaxis. Neuromuscular blocking agents, particularly succinylcholine, are the most common cause of allergic reactions during surgery. Epinephrine, our friend epinephrine, is a potential potent vasoconstrictor that is considered the first line of treatment for anaphylaxis in surgery. Hypotension that occurs is going to be treated with vasopressors such as antidiuretic hormone, norepinephrine, and milrinone. Corticosteroids such as hydrocortisone and methylprednisolone might also be used to treat anaphylaxis in surgery. Blood transfusion reaction is an infrequent occurrence, but its infrequence doesn't make it any less important. The three types of transfusion hemolytic reactions are febrile, non-hemolytic, allergic, and hemolytic. Febrile non-hemolytic is caused by antibodies binding to donor white blood cells or platelets, and it's really rarely encountered in the surgical setting. It's characterized by a rise in temperature and is usually treated with acetaminophen. Allergic transfusion reaction is usually mild, and it's caused by either medications taken by the donor or from the additives that are used to prepare the blood products. Now, hemolytic reactions occur when incompatible blood or blood products are administered to the patient, and this leads to hemolysis. Signs of a hemolytic reaction are going to include hypotension, hemoglobinuria, anuria or oliguria, which means either no urine or a scanty amount of urine, fever, and something called disseminated intravascular coagulopathy, DIC. Now, DIC is a condition in which small blood clots develop throughout the bloodstream, and they're going to end up blocking small blood vessels. But this increased clotting is going to deplete the platelets and those clotting factors needed to control bleeding. And that is going to lead to a reverse effect, which is excessive bleeding. Hemolytic reactions are first treated by discontinuing the blood product, followed by control of hypotension. Diuretics may also be administered to maintain kidney function. Bronchospasm is defined as impaired breathing from contraction and inflammation of the bronchi. Bronchospasms may be triggered by mechanical or chemical means. So mechanical, an example of that would be the insertion of the ET tube. Chemical would be the administration of some medications. Chronic obstructive pulmonary disorder, COPD, mucosa edema, and inflammation of the airway might put the patient at a higher risk for bronchospasm as well. And if the bronchospasm is associated with anaphylaxis, the treatment is as I previously discussed. Some signs of bronchospasm include wheezing, prolonged exhalation, decreased breathing sounds and oxygen saturation, increased airway pressure during positive pressure ventilation, and hypotension. Treatment consists of administering 100% oxygen and then manually ventilating the patient, which of course will be done by the anesthesia care provider. A group of drugs called B-adrenergics are particularly effective in treating bronchospasm, and some examples include albuterol, terbutaline, and epinephrine. And these drugs are either aerosolized and administered through the ET tube, or they are given subcutaneously. Anticholinergics such as atropine and epetrabiole may also be administered. If bronchospasm persists, corticosteroids such as hydrocortisone and methylprednisolone may be delivered in aerosol form as well, but they're usually given IV. Laryngospasm is another example of an emergency situation that you might encounter in the operating room. It's defined as the involuntary constriction of the vocal cords that may result in partial or complete closure. The image that you see on your slide shows a normal larynx on the left half of the picture. You can see that the larynx is nice and open, and you can see right between the vocal cords down into the trachea. The image on the right half, you can see that the larynx is extremely constricted and there's really no space there at all. So if a laryngospasm is going to occur, it's the most frequent during intubation and extubation. Patients are most at risk for laryngospasm if they are lightly anesthetized at the time of extubation, removing the ET tube. So while it can occur in adults, laryngospasm is seen more frequently in children and infants. And if the spasm doesn't respond to positive pressure ventilation and pulse oximetry is showing oxygen desaturation, so their O2 level is going down, 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 a dose of depolarizing muscle relaxant like succinylcholine will be administered intravenously. Atropine might also be administered in pediatric patients to treat bradycardia that is caused by the desaturation of oxygen or hypoxemia. Cardiac arrest is the sudden unexpected loss of cardiac function, breathing, and unconsciousness. Cardiac arrest may occur at any time before, during, or after an anesthetic is given. Cardiac arrest and respiratory arrest in the operating room is referred to as a code blue. And when a cardiac arrest occurs in other departments of the hospital, an announcement is typically made throughout the hospital to notify members of the code blue team to report to the location of the arrest. Well, this is not typically the case when a code blue occurs in the operating room. Instead, surgical personnel are going to serve as the department's own code blue team. During a code blue in the OR, the anesthesia care provider is going to provide the diagnosis as well as call and lead the code. They will also be responsible for securing and maintaining the airway, monitoring the patient, and administering medications as needed. So they have a huge job. The circulating nurse often retrieves supplies and documents the code and is there to assist all personnel as needed. Because there's a chance that cardiac arrest might occur in the operating room, all surgical technologists have to be certified in American Heart Association Basic Life Support, BLS, at the healthcare provider level. Given the scenario, the surgical technologist's role is going to vary. In my experience, the primary role of the surg tech is to protect the sterile field. However, you may be asked to get the code cart or assist with compressions. in my time in the operating room, I witnessed 2 cardiac arrests, and if you are at a level 1 trauma facility, which I was not, you're probably going to experience it a lot more frequently. I remember the first time that I experienced cardiac arrest, we had this elderly patient. Surgeon had significant doubts about the success of the surgery, but the family made the decision that they wanted to go ahead with the surgery and do everything that we could. So we did. And we're in the middle of surgery, and her belly is wide open when she codes. So I was with the first assist, the RNFA that was helping the surgeon, and we started compressions while the surgeon went out to talk to the family to see what they wanted us to do. While we were doing chest compressions, one of us had to put a towel over the abdomen to keep the guts from spilling out when the other person did the compressions. And the OR table doesn't go down extremely low, and if you're not a really tall person, even a step up isn't really going to help that much. It was absolutely exhausting. It felt like an hour and 20 minutes, but it was probably only a few minutes before the surgeon came back and said the family doesn't want us to resuscitate. So that was my first experience. Another experience I had, we were doing a total hip replacement, and the patient was in the lateral position. We were putting the staples in the skin, so we were just finishing up when the patient coded. So I was instructed to break scrub and go get the code cart. So as the surge tech, whether you're a student or a staff member, you must know where the code cart is because you might be asked to go and get it. So I retrieved the code cart. I helped to place the pads onto the patient, and then we shocked the patient. We were able to resuscitate her and then take her to the recovery room where she went home and recovered, and she did well. So regardless of the role that the ST plays during resuscitation, it's important that we also understand the medications that are commonly given to treat cardiac arrest. Now, all of those medications are going to be on the code cart. Again, you need to know where the code cart lives in case you need to go get it. And in some capacities, you may be responsible for testing the defibrillator on the code cart when you come in for your shift, which I have done in the past as well. So epinephrine is often the first line pharmacological treatment for cardiac arrest, which is also referred to as a systole. Vasopressors are also used to restore normal heart rhythm. And there are several categories of cardiac resuscitation medications, and they include adrenergic agonists, adrenergic antagonists, cholinergic agonists and antagonists, antiarrhythmic agents, vasodilators, inotropes, and vasopressors. So we're going to learn a little bit about each of these categories of medication. Several medications are labeled as agonists or antagonists. Remember, an agonist is a drug that binds to the receptor, producing a similar response to the intended chemical and receptor. Conversely, an antagonist is a drug that binds to the receptor either on the primary site or on another site, which altogether stops the receptor from producing a response. Now, adrenergic agonists are also called sympathomimetics, and these drugs mimic the effects of epinephrine and norepinephrine. So let's talk about a few different ones. First is dopamine. Dopamine is used to treat bradycardia because it increases blood pressure and cardiac output. Phenylephrine causes peripheral vasoconstriction, so it's effective in treating hypotension. It's going to help increase the blood pressure. Dobutamine is used to treat hypotension and cardiac failure. Then we have isoproterenol hydrochloride, and that increases the rate and force of the contraction of the heart muscle, which is the myocardium, and it's used to treat bradyarrhythmias, and it also serves as a bronchodilator. Norepinephrine, we've talked about before, is a vasoconstrictor, and that can help to increase blood pressure as well. And then lastly, albuterol and terbutaline are effective in the treatment of bronchospasms, and I mentioned them before as well. Adrenergic antagonists are also called sympatholytics. More specifically, they're characterized as beta-adrenergic antagonists. You might also hear them referred to as beta blockers. These medications block the effect of epinephrine and norepinephrine. Some examples include atenolol, metoprolol, and labetalol. These are considered class 2 arrhythmic drugs, and they're used to treat tachyarrhythmias and hypertension. Cholinergic antagonists are called parasympathomimetics, and cholinergic antagonists are referred to as anticholinergics. Now, cholinergic agonists mimic the effects of acetylcholine. Cholinergic agonists are not utilized in the treatment of cardiac conditions. Some examples include pilocarpine, which is used to treat glaucoma, and neostigmine, which is a reversal agent for non-depolarizing muscle relaxants. Now, cholinergic antagonists, however, are used to treat cardiac conditions. And as you can see by the image on your screen, these drugs block the effect of acetylcholine. For example, atropine sulfate is used to block the effects of the vagus nerve. Remember, that's cranial nerve 10, and the SA node, which is the pacemaker of the heart. It's also used to treat bradycardia, and it will raise heart rate. Antiarrhythmic agents are used to prevent or treat irregularities in the force or rhythm of the heart. Many of these agents are grouped by classes, but there are some random ones that we'll talk about as well. So let's start by talking about class 1 antiarrhythmic agents. These are sodium channel blockers, and they are used to treat ventricular fibrillation and tachycardia. And they've mostly been replaced with class 3 drug called amiodarone. Some examples of class 1 include procainamide and lidocaine. Class 2 are our beta blockers, and they're used to treat tachyarrhythmias, as I discussed previously. Atenolol and metoprolol are examples of class 2 beta blockers. Class 3 are potassium channel blockers, and the most common one is amiodarone, like I mentioned before. And then finally, class 4 antiarrhythmic agents are considered calcium channel blockers, and they reduce the flow of calcium into the cells of the heart and the blood vessels. And this is going to cause relaxation of the blood vessels, which we refer to as vasodilation. Two examples of these are diltiazem and verapamil. And then some outliers. Adenosine is also considered an antiarrhythmic, but it's not classified as the others are. It might sound familiar to you. It is a naturally occurring nucleotide that is part of ATP, which is adenosine triphosphate. This is the energy that our cells use and is manufactured through the process of cellular respiration. So this is used to treat supraventricular tachycardia, which is a super fast and irregular heartbeat of the atria, the upper chambers of the heart. So as previously mentioned, vasodilators relax the vessel walls, reducing blood pressure, whereas inotropes and vasopressors are used to increase blood pressure. Nitroglycerin and nitroprusside are used to treat angina, acute myocardial infarction, which is heart attack, and congestive heart failure, CHF. Dopamine and epinephrine are both inotropics, and they increase the force of the cardiac muscle contraction, and they are also vasopressors, which stimulates vasoconstriction. So let's talk about malignant hyperthermia. Malignant hyperthermia is rare, and it is an inherited muscle condition. It's considered a life-threatening reaction, and it is triggered by certain anesthetic agents. And once it has been triggered, malignant hyperthermia, or MH, we'll refer to it as, can be fatal in as little as 15 minutes. So prompt diagnosis and treatment are going to be really crucial. If MH is untreated, mortality rate is 80%. Now, the agents that are known to trigger the disease are succinylcholine and any and all inhalation anesthetics except nitrous oxide, which is laughing gas. So MH, like I said, is an inherited muscle condition, and it causes a hypermetabolic state in patients exposed to triggers. MH is estimated to occur in 1 in 15,000 children and 1 in 50,000 adults. More than 50% of the cases, interestingly, are observed in patients younger than 15 years of age. For the disease to occur, both the trigger and the inherited susceptibility have to be present. And when the triggers are administered, like succinylcholine or inhalation anesthetics, what's going to happen in the body is massive amounts of calcium are going to accumulate in the muscle cells, and that is going to cause sustained contractions. That's going to burn a lot of energy and create a lot of heat. Glycolysis is also going to occur there. So there's a depletion of oxygen, which means an increase in carbon dioxide, which is going to cause acidosis. That's a too acidic of a blood pH, and muscle cells are going to break down. And the breakdown of the muscle cell is going to release potassium and myoglobin, which is a muscle protein, as well as creatine kinase. And this is going to lead to a clogging of the kidneys. So in this whole matter, we're also worried about the kidneys as well. So while the name malignant hyperthermia suggests that that a rise in temperature might be the first sign, the earliest sign of MH is actually an increase in end-tidal CO2. Remember, that's the amount of carbon dioxide that the patient is breathing out. That is going to start going up, and an increase of even 5 millimeters of mercury could be significant. The end-tidal CO2 can increase for reasons other than malignant hyperthermia, but once they've ruled out all other possibilities, the anesthesia provider may alert the operating room staff that an MH crisis may be at hand. Other early signs include tachycardia, tachypnea, masseter muscle rigidity. That's the muscle that when you're chewing is flexing, that muscle there on the sides of the face. Unstable blood pressure, arrhythmia, cyanosis, which is like a blue tinge to the skin, diaphoresis, which is sweating, and pyrexia, which is fever above 100 degrees. Other late signs could include skin mottling, myoglobinuria, and hyperkalemia. So, what do we do to treat malignant hyperthermia? That's easy to remember with the acronym HDSTDI. How do surgical technologists do it? The H stands for hyperventilate. So anesthesia care provider is going to administer 100% oxygen. This is going to help to eliminate excess carbon dioxide in the blood. D stands for dantrolene. Dantrolene is the medication that was developed specifically to treat malignant hyperthermia. And it needs to be reconstituted with IV saline, and then it's administered IV to relax skeletal muscle. In 2014, the FDA, the Food and Drug Administration, approved a new formulation of dantrolene, and that's called Ryanodex. The S in the acronym stands for sodium bicarbonate, and sodium bicarbonate is used to counteract the metabolic acidosis caused by the increase in carbon dioxide and hyperkalemia, too much potassium. The T stands for temperature management. So we need to get ice, and we need to get it fast, and we need to pack the groin, the axilla, and the neck with ice. We might also lavage with cool irrigation, and all of these are an attempt to reduce the fever associated with MH. D stands for diuretics. The patient is going to be given a mixture of Dantrium and mannitol, and this is going to help increase the kidney function. And then lastly, I is for insulin, which is also used to treat hyperkalemia. Insulin is going to enable the cells to take in glucose, and glucose carries potassium inside the cell with it. So this is going to reduce the potassium levels in the blood. It's important to note here that each OR department has a malignant hyperthermia cart that contains all the medications needed to treat malignant hyperthermia. Be sure you know where this cart is located so that in an emergency, you'll be able to retrieve it quickly if instructed to do so. Also, be sure to familiarize yourself with the facility's MH policies and procedures. So you might be wondering, what is your role in all of this? First, and most important, remain aware of the patient at all times, as well as the environment. If you're not paying attention to what is going on with the patient, you are not going to be much help early on in the crisis, or at any point for that matter. Know what to look for. Look for the clinical signs previously discussed and be ready to respond when and as needed. Rapid response is going to increase the survival rate of our patient. Focus all of your attention on the patient and the needs of the anesthesia provider in dealing with the crisis. And when the anesthesia care provider indicates that there is a crisis, you want to stop what you're doing immediately. Once malignant hyperthermia has been identified, the surgical procedure is going to stop and all triggering agents are going to be discontinued. And if the procedure continues and you are serving as the first scrub, stay sterile and monitor the operative site and the sterile field. You may also be asked to help close the wound or hand iced saline to irrigate the cavity. When appropriate, the surgical tech in the second scrub role might break scrub to help run for ice or get additional people to come and help, or if no other personnel are available, they may help reconstitute the dantrolene. It is not within our scope to administer the dantrolene, so remember that. If you are assisting the circulator, you might also be asked to get the malignant hyperthermia cart, call for help, assist the anesthesia care provider, set up ice lavage, or reconstitute the dantrolene. Remember that these tasks run in parallel. Like, this is an emergency. There's going to be a lot of stuff going on. Knowing the procedure and being prepared to act adds value to the surgical team during a crisis situation. Be prepared to act, but don't panic. You don't have to panic. Patients that are known to be at risk of malignant hyperthermia are going to remain safe because they won't be given those triggering agents. In my career, I've experienced one case of malignant hyperthermia. It was a 13-year-old young man who had been diagnosed with appendicitis. So we brought him in to take out his appendix, and I was setting up my field, and anesthesia was doing their thing. And I had my stuff all set up and was just kind of waiting as they, finished preparing the patient. The nurse was getting ready to prep when the anesthesia care provider said, "I think something is not right. The patient's CO2 is too high." Needless to say, the patient was experiencing malignant hyperthermia. So in my situation, I was instructed to break scrub, and I did help reconstitute the dantrolene. I did draw it up into the syringes, but I did not administer it, of course. But I helped with that. I also helped get the ice that we used to pack the patient. Thankfully, we weren't in the middle of a procedure. So we were able to get the crisis under control, and he spent the night in the hospital. And then the next day, thank goodness too, his appendix wasn't ruptured. It was urgent, but it wasn't emergent. So they were able to let him recover from that situation and bring him back early the next day and remove his appendix. And, when they did that, they made sure that they didn't give any of those triggering agents, like I had mentioned before. So there are several important takeaways from this lecture. First, malignant hyperthermia is just one of the emergency situations that might arise in surgery, as we learned. And regardless of the situation, they all require us to think quickly and provide assistance efficiently and effectively. This is why the more information the surgical technologist has, the more effective he or she is going to be in an emergency situation. As always, thank you so much for joining me. My hope is that this lecture contributed to your learning and your ability to provide top-notch quality patient care. Not only do I thank you, your patients and communities are going to thank you. You have my utmost respect and gratitude. See you next time. Be safe out there. Take care.